Dr. Vivek has completed. I invite Dr. Vivek for his talk on thyroid ophthalmopathy, how to tackle the diplopia surgically. Dr. Vivek has completed his medical education from Nasik, and then he has done his residency from Darbhanga Medical College. He has done 2 fellowships from LVPI, one in comprehensive and one in pediatric ophthalmology and three in fact. He's joined LVPI Bhubaneswar campus as faculty since 2013. Vivek has presented papers and published papers and videos and delivered invited talks at various national and international ophthalmology forums. His area of interest include pediatric cataract, strabismus, neuro-ophthalmology, and he has served as a task force officer for RBSK program of NHM Odisha for congenital cataract, and he's recently completed an international fellowship in complex strabismus at Boston Children's Hospital, Harvard Medical School. So his views will help us to understand thyroid ophthalmopathy better. Dr. Vivek, please.
Yeah, so thank you so much, Dr. Shubhangi, for nice introduction, and thanks for giving me this opportunity to present in this IC. So good morning to everyone. So basically today I'm going to talk about how to tackle the strabismus in thyroid eye disease. So I think this is the Rundle curves which every strabismologist who operate or deal with the strabismus in thyroid eye disease, they are aware about. So we need to be very much clear about the activity of the thyroid eye disease. So as we know that there are different phases, right? So the dynamic phase where the patients have the very active and severe thyroid eye disease, then it becomes a plateau, then the activity goes down slowly over a period of time, and disease become the psychiatrical. So once you are aware about that, you can take the calls for taking strabismus surgery in this group of patient. So abnormalities of extraocular muscles on imaging is seen in almost 80 to 90% of the patients with TED. Clinically, they are apparent in 30% of the patient. So ocular deviation is the most common presentation, followed by diplopia, and the most common strabismus pattern that we see in our practice is hypo and esotropia, for the obvious reason, because the extraocular muscle involved in a descending order could be IR, MR, SR, and then the LR, which is least common. 3 to 8% of the patients, the myasthenia gravis is associated with a kind of a thyroid eye disease, and you need to be very cautious because we know that the OMG is a masquerading. So you need to suspect and subject appropriate test so that you can rule out that there is an underlying ocular myasthenia associated with TD. So let's start with this particular patient, 53-year-old lady who is a housemaker, presented with double vision, horizontal and vertical diplopia since 6 months, and there was associated drooping of the left upper eyelid. So if you see that this is her past medical history where the neostigmine test was positive and ACH receptor antibodies were negative. So she was put on the medications, and there was a past medical history of various disorders that she had, like seizure disorder, hypothyroidism. She was on n number of medications. So if you see, the most important examination that we should focus on whenever there is suspected ocular myasthenia is pupil, right? So there should not be any kind of anisocoria or something like that, and once you are pretty sure, then you can always subject this patient for treating the strabismus. So look at this, how severe is the hypertropia, and no peri-orbital puffiness, no episcleral injection, no chemosis. That means, as we learn, the first slide, like according to the Rundle curve, the disease is pretty much in kind of quiescent. So we don't need to worry, and you can actually take this patient directly for the surgical intervention. So you can appreciate standard plus 9 gauge photograph, how gross extraocular motility limitations, especially the left eye elevation limitation, and very large hypertropia in primary gaze. So how to deal with this? Make sure that the thyroid profile is within the normal range, endocrinologist has seen, and things are in place as we discussed. So then sometime all these patients, it's important to subject them for neuroimaging to understand what is the pattern which is correlating with what type of extraocular muscle enlargement. So as we can appreciate here, the uh, inferior rectus and the medial rectus, in fact even the lateral rectus, they are enlarged. So that will help you to take a surgical decision of the same eye surgery. In addition to that, do you want to add any other extraocular muscle in the other eye, so that you can take care. So basically there are non-surgical and surgical ways to operate these patients. So non-surgical ways to control the thyroid hormones, cessation of smoking, intravenous or oral steroid depending upon the active stage of the thyroid eye disease. If required, immune modulation. Having said that, once the medical treatment is done, still these patients, they get debilitating diplopia to deal their day-to-day life. So you have other options, temporary measures, where until you plan actual surgery, you can offer them the different type of prisms like slab arm prism, then the Fresnel's prism, or monoocular occlusion, or depending upon how much is the primary deviation. If it is a smaller amount, you can always offer the botulinum injection. So this is what the prerequisite I follow in my practice: 4 to 6 months of stable deviation, no signs of active TED, and stable systemic control. And that's the way to go for. If you want, there is a extensive the proptosis and strabismus in TED, then this is the sequence of surgeries that we should go about, like orbital decompression, strabismus surgery, and then the last one is the lead surgery. So this is we have recently published that, like, what are the strategic decision making when you deal the strabismus in thyroid eye disease. So binocular vision in a functional position of the gaze is a important the goal, especially the primary and the down gaze. That's what we utilize this gaze more often, and the expansion of the binocular visual field. So how to tackle? Let's talk about like hypotropia, IR recessions, unilateral depending upon the primary deviation, or a combination of the contralateral superior rectus recession. So I'll just take you through this particular case. So continue the systemic medication, get the fitness for general anesthesia, which is very very important. These patients are very high risk, on table kind of the cardiac arrest and all. So you need to be very careful. Intraoperative FDT is again the most important test for strabismologists to look for, and decide your surgical doses and plan on table. So in this particular patient, ipsilateral IR recession and contralateral SR recession was planned, and you can appreciate that there was 40 prism diopter LHOT with 8 prism diopter exotropia. That's how the on day 1, and then day 8 weeks, I mean almost 2 months, you can see that there is a remarkable improvement in the hypertropia. However, these patients, when you tackle the IR, usually end up with getting the kind of lower lid retraction, which sometimes our plastic colleagues, we need to ask them to correct for the cosmetic purpose. So this is how the summary of this particular patient. So very gratifying outcomes. This is another case, a chronic smoker, already a hyperthyroid patient on treatment. Hormone levels were pretty good. However, he has developed very severe hypo and esotropia. He was on a treatment, and then you see the extraocular muscles. So IR and MR are extremely enlarged, and that's how they are pulling the eye down and in. So you need to, again, this very severe hypertropia and esotropia, so you need to subject them to the multiple surgeries, and you would find that they would do amazing if you have a very systematic plan their doses, considering many factors as we discuss, and on table FDT is a crux over a period of time. So you can appreciate this patient needed the second surgery, where the other eye SR was dealt, and you can see that the first and the last follow-up outcome. So they do good. What are the surgical challenge? Reoperation rate is little bit high. Recession is preferred over the resections. Whenever there is a large deviation, you can opt for standard nomograms. Are really unpredictable. the one which we follow for the routine, horizontal or vertical surgeries. Post orbital decompression, this is the rule of thumb probably in my practice. Larger than expected recession for a smaller deviation, and smaller than expected recession for the larger deviation. As we know, the reason behind this, because the vertical fusional amplitude is somehow quite high in patients with thyroid disease compared to non-thyroid patients. So what are the precautions? Meticulous handling of the conjunctiva, because it's very pliable and foreshortened, so you have to be extremely careful. Conjunctival closure, spatial hooks as and when required. Super tight recti, you need to use the Cowell hook to prevent the rupture or the pulled into syndrome on table. 15 number Bart Parker blade is also another option to disinsert the muscle. So A pattern horizontal deviations are more common. MR recessions aggravate. Keep this in mind. Be careful, watchful. Explain to the patient before you go for surgery. In cyclotorsions, contralateral inferior oblique overactions, lower lid retraction, proptosis is a prominent. So there are multiple things you need to take care and counsel to the patient at the same time. This is another entity. Whenever you touch to the IR, be aware about the progressive overaction of after IR recession. So over a period of time, this patient might go into the hypertropia. So you need to be very, very careful and understand like why does it happens, and that really helps you to, because it's always better to undercorrect and do the other ISR in case you want to tackle the large hypertropia, rather than doing extra large recessions and then post-operatively ending up with the hypertropia. So to conclude, the control of risk factors and stable endocrine status is extremely important. Avoid the surgical intervention during active phase. Strabismus surgery not before 4 to 6 months of stable deviation. And the goal is binocular vision in functional position of the gaze. Standard surgical nomograms do not apply. Keep FDT as a standard of care. Recession are preferred. Resections is large deviation. You can always take help. Progressive overcorrection, that you need to be keep in mind. Adjustable suture is another the viable option to tackle the diplopia. And chronic disease, long-term follow-up is needed. Thank you very much.
For a very well covered the topic, covered the topic very well. I just want to ask one
Yeah.
question to you.
Yeah.
Do you prefer always an adjustable or conventional recession?
Yeah, I do the scleral conventional fixation technique in my practice. I usually plan to little bit under correct them. So if there are very large deviations, I bring them in a range where we can use slab of prism or Fresnel's prism. But somehow the vertical
Millimeters in terms of
yeah,
millimeters,
so in
not
terms of millimeter,
millimeters.
1 millimeter in thyroid eye disease, I calculate it as a 3.5 prism diopter. So that helps me to
Do you go beyond 5 millimeter or more?
no, that's what for inferior rectus, I don't take that risk. However, like other recti, even superior rectus, I don't mind to go it like 7.5, because they don't affect even the visual field wise, because we are a little bit we have to be careful. If you recess more the IR, either I will go hyper or the field of
Which is more
is
important
more
for you?
affected. So we don't want that.
So, and what type of suture do you like, vicryl or non-absorbable?
I use in my practice vicryl sutures. They do very well.
Because sometimes they say that
Yeah, they if because of the weight of the muscle, sometimes they get cheese wire and
yeah.
go down. Yeah, that possibility is always
No
there.
a nasal shifting of the IR to prevent the torsional anything or
If like this particular case, there was kind of extortion in this particular patient, but it's not bothersome. So in until and unless like patient is complaining tilting of image or something, I don't do it. But yes, that has shown that that takes care of
some amount of nasal shifting of
shifting
the
would help.
muscle would reduce the concern.
Yeah.
Regarding Botox, I think for active case of thyroid, we use steroids and try to reduce the inflammation. And then we wait for some time before we plan the surgery. So that recurring period, can you use Botox? Is that an
Yeah, I mean, what I have tried actually, couple of patients, but in my experience, if you do a Botox alone, until and unless, it's a small amount of deviation, it doesn't help, right? If it is a large deviation and you just give a Botox, it's like nothing, no effect. If you are giving it accompanying the strabismus surgery, considering the large dose beyond the range of your surgical nomogram, then Botox add, and then you would get optimal result. That's how Dr. Granite's paper talks about. But that concept of like how come the Botox and the thyroid muscle, they are fibros, that is no more valid now. Botox do work in a patients with thyroid eye disease.
Have you ever tried putting a post-fixation suture on contralateral IR?
Yeah, that I have shown in one of the slides. So I have tried 2 to 3 patients, and it works actually to have the balance effect. So it's kind of a fed of doing the contralateral IR. Yeah. Thank you. Thank you very